Greetings, Mark Garang here, publisher of the Conway Daily Sun, and today joining me are Tricia Costigan, who's the president of Memorial Hospital, and our own Terry Levitt, who's our health editor, among other things. How you guys doing?
Very well.
Good. Tricia?
It's a beautiful day.
It is a beautiful day. It's town meeting day for us, for some of us anyway. So you've been here a year, right? Just about a year.
Yep.
And then I looked at the story that we did when you arrived, and you said you're like living the dream. You're from rural, I mean, you've been around, but you're from rural Maine.
I am.
So coming here was like a dream, you said.
It
so
is.
are you living the dream?
Yes, absolutely. My husband and I love it here. Our kids, they're older, but they get to come visit. My mom visits, my in-laws visit. We love it here. Our whole family loves it here. So
Which town did you settle in?
we settled in Eaton.
You did?
We did.
Oh, nice.
Yes, we're very, very, very happy. We found, when we knew we were moving, we created a kind of a wish list of what we would like to find in a property, and we found it all. So we are super happy.
Nice.
Yep.
Eaton's a great town.
It is.
You can go up to Foss Mountain. You can do all kinds of
We
things.
can.
Yeah.
Hiking is on my list of things to do this summer. We have our camp in Maine still, but trying to split our time so that we can experience the outdoors here as well.
When you're not working 24/7, that is.
Well, you can take a phone with you.
There we go. All right, so I guess, Terry, you want to start with urgent care? Is that where we...
Yeah. MaineHealth has just opened the urgent care last month down on the Strip in North Conway, and they had the ribbon cutting yesterday. I think that was your first time there as well as mine.
Mm-hmm.
How did you find it?
I think it's a very good use of the space that they have. I think they offer a lot of services for 1,200 square feet, and the numbers from the last month, they've seen over 450 people in the first month that they were open, even before the ribbon cutting. So that's a lot, which is proof that we needed it.
Just for comparison, how many people would go to the emergency department in a month? I know you're hoping that some of the cases that you were seeing in the emergency department that didn't need emergency care would go here. So
We average between 45 and 50 a day.
okay.
So you can do the math on that. I only look at the day-to-day to see where our trends are. But
Yep.
so it's not, and urgent care doesn't necessarily cut into the emergency room. What it does do is it offers a service to people who wouldn't seek service otherwise. They may wait for primary care. In our area, they may wait till they went home. So they have an opportunity to get seen for things that don't necessarily require an ER visit, but they would be more comfortable if they sought treatment sooner.
So this is, I mean, it's when you say they, but it's you, right? This is MaineHealth. This is Memorial Hospital.
So I'm talking about patients.
Okay, but I mean, in terms of the urgent care center, it's part of Memorial Hospital MaineHealth.
It is not part of
Nope.
Memorial Hospital. It's a different branch of MaineHealth.
Okay.
And it was done that way deliberately, not to make it a sub business of a hospital, because that allows us to do different pricing structures and to address the cost of care to make the urgent care cheaper than it would be if it was attached to a hospital.
So you don't, I mean, you as president, so you don't hire employees there? That's all? So what is I mean, obviously this, I mean, you work together, but just what you said, right? I mean, what's the hospital's role? I mean, I guess let me back up.
Okay.
Why do we even need one? I mean, what happened to the old emergency room walk-in clinic that Memorial had?
So the volume of acute care and the way that we use our footprint in the emergency room, the walk-in piece of Memorial was closed well before I got there, and it's been transitioned into true emergency room space.
And why was it closed?
I wasn't
Okay.
here, so
Okay.
that one I don't
Okay.
know. But if you look at lots of insurance plans, the out-of-pocket expense for the patient is much cheaper if they go to an urgent care versus if they go to an emergency room. And justifiably so. There's a lot of things that don't need the level of care that we provide in the emergency room. So why do we need it? We need it to fill the gap between what would be a primary care visit that might be able to wait a day or 2 or 3 and what is a true emergency. It gives patients an option. Specifically in North Conway, we have a huge volume of visitors. It gives them an option because they don't have any relationship with any of the local primary care providers. So their options were either to go to an urgent care that was somewhere out of the area, or to go to our emergency department, which really isn't the right place for a lot of things that,
Sure.
that we see.
It doesn't cut in, I mean, obviously you work together, you complement each other, but doesn't it cut into the Memorial Hospital's business? Well, you don't see it that way.
We don't see it that way. We see it as establishing the right venue, the right level of care for what the patients need. We don't have, if healthcare anywhere is in a place where the demand is much bigger than the supply.
Okay.
So if we can find a way to do things more efficiently and more appropriately, especially at a lower cost point to us, like our lower expense point to us as MaineHealth, and to the patients at their out-of-pocket expense, that's the right thing to do. We can adjust on the other side. I did ask our staff, our emergency room staff, like, how do you feel about this? Is not seeing tick bites and little things that would potentially go to urgent care, is that going to affect your job satisfaction? And the answer was no, because those little things, we are honored to serve everybody, but having some of those go to the urgent care allows us to really focus on the people who are there that need us, that are critical.
I've one more question, we can move on. So if I'm a local, because obviously you get people out of town and just whatever, and that's totally makes sense for them. But what if I'm, which I am, a local, and so I have a primary doc and I just have something, you know, bad flu or whatever. Now, would it be tempting just to go to the urgent care, or would I just call up my doc and go to the primary care? Like, how does a person here make a decision where to go, you know, for something that's not an emergency?
Sure. So the role of primary care, in my opinion, you would always want to start there because they have a relationship with you. We know you, they know you, and that's the whole point of primary care, is to kind of come alongside you in your wellness and health journey. So if you're a local, I would suggest that you start with your primary care. The urgent care is open in hours that primary care isn't. And then it's also a matter of, if primary care, can we fit you in a time that seems reasonable to you? If we can't, then you have an option.
Okay, so if it's the weekend, one more question.
Sure, no problem.
So one more local question. So
Yep.
if it's a weekend, the hospital's basically closed, primary care guys are out fishing, whatever, and women are out fishing, whatever they do, or skiing. I cut myself. I just don't think anything of it and just go to the urgent care.
No problem.
Okay, and it's fine, because then on Monday you call a primary care and say, hey, I get 10 stitches in my thumb, and life goes on.
The way that because it's MaineHealth and we're connected and we're all using the same electronic medical record, if you did that and your primary care was with us, then they would know. They would get a notice.
Okay, so it all goes on the Epic system.
It does.
Okay, I'm done. Terry?
So you mentioned financial issues when we were talking about urgent care, and I think finance is a huge elephant in the room for everyone involved in healthcare, whether you're a provider or a patient.
Agreed.
And we're seeing a lot of changes in funding. Medicaid, there have been Medicaid cuts. Insurance prices are going up. And we also have the Go North grant funding for rural health care. And I guess I'd like to talk a little bit about all those things and how they're affecting both the hospital and patients. Where do we start?
The Medicaid cuts. But the Medicaid, since you ended up 4 things, the Medicaid cuts, but they haven't kicked in yet, right?
Correct.
It's right. So
And you're talking about the eligibility,
well,
Medicaid cuts to
yes,
eligibility,
the work requirements and all that stuff.
We really haven't seen an impact from that. I don't know if it's yet or how that will affect our community members, but we're definitely keeping an eye on it. We're prepared that some of those patients may qualify for free care, so that means that the hospital would essentially write off their care.
And what about, but what has happened though is the Obama subsidies have expired and then haven't been renewed. So how are you feeling that on because we know we have people here, you know, premiums have gone up.
Right.
How are you experiencing that at the hospital?
At this point, we're really not seeing a big difference. We are seeing our free care. So we have a policy, I think it's 200% of the poverty level. And we have a sliding scale. So people qualify for help and discounts with us. So we are seeing our free care go up. Now, whether that is directly attributable to those changes in the policy or not, we
Like
haven't.
people I mean, if your free care goes up, that would suggest that people are just dropping their health insurance.
or they're in a position where they can't pay their copays. Free care is not necessarily that they don't have health insurance. It might be that they have a large deductible and they qualify. So there's lots of things in that policy that if it's kind of commingled. So we don't have enough time yet in the year to be able to pull enough of the data apart to figure out exactly what's
How
going on.
much free care is a overall financial question? One is how well does the hospital do? Like how much money, what's your profitability? Is it 5%, 10%, whatever, no percent? And how much of all your services are free as a percentage?
I don't have those numbers off the top of my head. They fluctuate every month, so I could get back to you with them, but I just don't
Okay.
have them off the top of my head. As far as how does the hospital do, that's a complicated question, simply because we are part of a health system, which means that we have a lot of services that are loss leaders where we make up for through the system, where the system helps us with that, and then we also have some where we make money because we have different funding, like our rural health clinic and things like that, which contributes back to being able to create a sustainable system. So it's kind of a give and take, which if we were a standalone, I don't think we wouldn't have any, we would be struggling much more than we are today.
All right, fair enough. You're not going to give us a percentage then.
I would, but
I know, I'm just teasing. I'm
yeah,
totally teasing.
it's complicated.
I'm sure.
Do you feel like, it sounded like you felt like the amount of free care is going up a bit at this
It is
point
going
already?
up. It is. But whether or not that's, what's feeding that, we don't know yet. It could be illness. Like it could be that people are sicker. It could be the Medicare Advantage plans changed this year, right? For Carroll County specifically. So that can have an impact. The exchange plans and the Obama era subsidies, those change. So there lots of things changed that contribute to our free care. We also have we live in a seasonal place, so sometimes people are not as employed as in the beginning of the year, like during the winter, as they are in the summer. So all of those things affect our sliding scale and who's eligible for financial assistance.
How do you decide, I'm sorry for asking these thorny questions.
That's
But how
okay.
do you decide like in free care? You were saying, well, some people, can't afford the deductible. So if you have an Obamacare, just a regular person, you have health insurance, but it's a $6,000 deductible, you can't, whatever. They come to you. How do you determine whether it's free or not to the person?
So we have a set policy that we follow where people can apply, and then we look at their income and the number of people in their household, and we use federal standards. So percentages of the federal standards, poverty standards, we use those to decide whether it's free or whether they qualify for a discount. But there's a very set policy so that it's fair to everybody. It is not subjective.
Good. So it's not like arbitrarily.
No, it's not like we like you so you qualify and we don't like you so you
I
don't.
thought
No.
that was the way. Hopefully that was the way it would work.
But you have to know this is available and talk to somebody in the finance department for the hospital and say, I have a problem paying this, and then that starts the process.
So we're very generous. So we have an access to care team, which is a MaineHealth based team that has representatives here, because this is a policy that's MaineHealth wide. And we actually will proactively talk to people that are having issues with their bills, or anybody that we think might be. So they can come find us, or we sometimes will reach out and offer, because not everybody knows it's available.
Let's go back before you.
Yeah,
go
go ahead.
You mentioned the Go North, the Go North Rural Health Program, which kind of goes under the radar, but it's a pretty big deal. Like the feds give like $700 million over a number of years in New Hampshire, and we get that. New Hampshire, and it's like $200 million for year one, and it goes all. It's like 283. This is over the 700 million. 283 million for the Foundation of Healthy Communities, whatever that is. 131 million to the New Hampshire Community Behavioral Health Association, plus the University of New Hampshire, and blah, blah, blah. So overall, is this like brand new money from the federal government, or is this replacing some other programs?
I think it's probably replacing other programs, and it's repurposed to have a definitive impact on the long-term sustainability of rural healthcare. It's exciting for us. I think as a community, we have an opportunity to benefit significantly. But we have to do things right. So I see the Go North program as a tremendous opportunity for the Valley, and not just for Memorial Hospital, because it's targeting overall health, right? And health is not just medical care. Health is, do you have food? Do you have transportation? Do you have housing? You know, all of those things. So by working with community partners here, which there are a lot, that's one of the best pieces of the Valley, is there's so many caring organizations with dedicated people to help our neighbors. If we can work together, I think we could have a huge impact. It's really not just the hospital.
Does the money, do you know if the money's coming through the hospital or is it dispersed to other organizations?
So right now, this is a new program for the entire United States. I will say that through MaineHealth, we were able to work with Maine and New Hampshire, not Memorial specific, but the MaineHealth team. We worked with both. New Hampshire did a fantastic job with their application, which is why they were probably the highest awardee. I know they were in the Northeast. Right now, they are working through the piece at the state level to figure out how to allocate this money out. We don't have the specifics yet on what we can apply for and what the guidelines are through each of those awards. Once we get them, we've had preliminary meetings with some local organizations like the Gibson Center and Home Health and Hospice and the Way Station to figure out how we can partner together to maybe apply for money that could help people, our community members, that doesn't necessarily have to come through the hospital, but the hospital can support some of the services that they would
Now,
like to offer.
the rural, I mean, it's called the Rural Health Program, so obviously anything north of Lakes region, and I guess on the west too, is rural, right?
Right.
I mean, that's us. I mean, we're
Right.
the heart of ruralness.
We are.
So do you have any sense of that, let's say that 200 and whatever is $205 million for this year, if it comes this year, next year, whenever. Like how much of that is going to come our way, like the Valley way, do you know?
We
Or how
don't
much
know
are you
yet.
going to, is that just part of the application process?
Right. It would be part of the application process, but we haven't seen the application, like the guidelines of how they're going to divvy out the money yet. We know that New Hampshire put in a very broad application, unlike other states that put in an application that kind of listed 5 things that they were going to do. New Hampshire did it in a way that created, I'm going to call it the buffet of services. So you could, as a community, you can pick and choose what you apply for based on, instead of having to do 1 of 5 things or 3 of 5 things. So once we really do need to see the directions on how to apply and what's available and how they're going to award funding. The good news is that if we do a really good job with this as a state, then there's more money in the future, right? We have to be good stewards of this money and show impact, and then there potentially could be this or not, or even more in the future.
I mean, it's 200 million, just one last thing. If there's 200 million in 1 year, I mean, the Valley, and never mind north of here, but the Valley could they benefit by millions?
Possibly, yes. That would be the plan, right, is to figure out what we need. I think one of the biggest challenges, and we've had these conversations internal to the hospital, but also external, is that this is made to, the intent of this money is to transform healthcare, which means that we're not looking to apply money to things as we've always done it. We're hoping to use this money to do things in a sustainable way. So I'm not sure that from a hospital perspective, it would make sense to apply for funding for a position, right? We want to apply for funding in a way that maybe creates partnerships and enhances partnerships in the community for the way station, right? To help people. How can we partner together to help that population that needs us? They need us both. So talking about and having creative ideas, that's where we're at.
So you have a team at the hospital that working on this now? I mean,
Yeah.
it's
Myself
one thing
and a
to say-
couple of others.
Huh?
Yep, it's myself and a couple of others. We've
Okay.
had some preliminary conversations. We're waiting for the guidance to come out as to how to apply or where they're hoping to send this funding and what directions they're looking for. And then we'll pull other groups together to continue to figure out how we can apply together. So we're basically on hold, just waiting. This is a lot of money for the state to figure out how to do it, and a year is a quick turnaround time. So I appreciate the fact that they are spending the time to make sure that we do it right from the beginning.
So it sounds as though that, I mean, it's one thing if you just got money just to subsidize some program, but if
Right.
you're doing new things,
Right.
then it sounds like that the more creative proposals will probably be the most successful.
Right.
So if you guys are the most very creative with this, we could the community could benefit.
Right, and I also think that it's not just about being creative, but it's about being, in the beginning, having kind of shovel-ready projects, things that we can do, even if they're smaller. So at the beginning, if we only do smaller projects, to show that not only if we receive money, we'll do what we said we would, and we can show results from it, right? So I want to create, I'm hoping we can create a reputation of asking for money, that we apply it where we said we would as a community, we show results, and then we move on to bigger things. I am very cautious of starting too big and not being able to produce the results that we promised, as much as this, we know this is a 5-year program, building the credibility that exists, that we know exists within the Valley, to show that we are good stewards of the money and we are performing as we said we would.
Okay, one more question with this.
Sure.
So so it reminds me of John Fuller, the closed John Fuller school. And I think you guys have talked, the hospitals talked to the school board about doing something. So, and people have talked about making a child care center or homeless, or there's a whole variety of ideas. So is that something that could fit in where you go and say, hey, we got this facility here, let's do something new. Here we go. That's a shovel. It's more than shovel ready. There's a building there.
Absolutely. So childcare is something that's we're really interested in, specifically around some of the conversations we've had with them about potentially childcare that has longer extended service hours as opposed to like 7 to 5, because our staff tend to work 12-hour shifts. So that's definitely a conversation that we would like to have about childcare. As far as the other things, I think that's a matter of us as a community being able to put our heads together and say, what is a great use of this space that could help transform, in the case of Go North funding, health in the Valley.
Are you still talking to the school board about John Fuller?
I actually have a conversation coming up, so yes.
So the hospital's interest in the John Fuller would be mostly childcare?
At this point, we don't need space, right? So we closed Merriman. We have space. We just haven't figured out what we're going to do with it yet, and that's a deliberate process we could talk about if you'd like. But I do think that space, we don't have any reason to incur the expense to rent space or extend into John Fuller, but it's possible that we could support other things that could go in there. But I don't know what those are.
Okay, Terry?
Well, you brought up MaineHealth,
Yes.
and it was on my list. So let's talk about MaineHealth. It closed, I guess, a few months ago now, and most of the patients or residents were placed at the newly, I've forgotten the name of the.
Mineral Springs.
Mineral Springs?
Well, I know it's Mineral Springs, but I've forgotten who's running it now.
603 Healthcare?
603 Healthcare. And so that was a fairly smooth process, you feel, for the families and the residents?
I think it was, I think for something that's as disruptive as it is, it went fairly smoothly. There's no way to close a long-term care facility and discontinue those services without completely disrupting the families' lives. Everybody feels better, and they know when they know that their loved one is safe, and then we say we're closing. That's scary. So I do feel that we did a really good job, and that our residents and their families were very open to having conversations about finding the right fit. So we appreciate all the support we received while we went through that process. And we have a very good relationship with 603 Healthcare and Mineral Springs as far as helping our community members. They have, from my perspective, they have lived up to their desire to transition that facility into a community treasure. They're doing a good job.
Good. And now you have this big open space.
We do.
Which I can't imagine will go open forever. So what are your plans for that?
So we are in the process of doing a master facility plan. So we have pieces of our building, of our infrastructure, like the main hospital, the old hospital, right, that everybody sees from the road, is over 100 years old. and it comes with some significant challenges. So right now we have clinical care in those spaces, which at some point we are going to need to relocate them. So in looking at the entire building, and we know that there's a sizable investment that needs to be made to kind of keep as a hospital, you have to make investments, but we have some aging infrastructure that's going to need significant investment. So we're looking really at what do we do and how do we do that? Holding the Merriman space empty gives us an opportunity when we figure out what our longer term plan is to transition different services into that space while maybe we fix theirs or rehab theirs. So it gives us an opportunity. I will say, in a hospital, keeping that much space empty is a challenge all in of itself, because everybody has ideas and they just want an office down there, or could they have space down there? And so holding it empty so we don't have to move people out to use it in the way that we would need to has been fun.
Gates. That's why they invented gates.
That's right.
How did that office get there?
Right. Who put this stuff in that room?
Did you have more about the?
Yeah, just a related one. So, Ridgeline down here by Walmart is planning, I guess, assisted care with a medical center. So, how does that complement the hospital if they have a medical center or in the assisted care?
So I haven't heard anything about a medical center, but there's no shortage of demand for care in the area. So I think whatever they do will be complementary, and it'll be to the benefit of the community. Assisted living, we don't have any here. So them putting assisted living in would be a great opportunity for people who don't need long-term care, but maybe aren't comfortable at home. So it's definitely one of the few services that we don't have in the Valley.
Okay. Terry?
Before we get too far away from the financial situation, I wanted to bring up legislation in Maine, LD 2196, which is presented as trying to lower costs for patients by capping, at least in large part, by capping what hospitals would be allowed to bill patients at twice the rate of Medicare?
200% of Medicare.
Medicare.
And MaineHealth has already put out significant statements about that would be devastating.
Correct.
For MaineHealth and for the health of people in Maine. Could you tell me why that will be a problem?
So for MaineHealth alone, if we did that, that's a $630 million a year hit to the bottom line, which means that we would have to make decisions on what services we could continue to operate. And it would put our level 1 trauma center, which is not cheap to operate. You don't make money on a trauma center. It's just the right thing to do. Our level 1 NICU is another example of a service that we offer in Portland that our local community benefits from, and that we transfer patients to them every day as well as to other places. It would make it so that we'd have to evaluate in rural health. We have a lot of services that we offer in rural health that there's no reimbursement for, and we make up for that in other ways. So capping that reimbursement would just make things difficult. I think we estimated that we'd have to lay off a third of our workforce, and you can't do that in all administrative. So that means that clinical services would have to be closed.
I mean, it's being proposed, and it's only in committee now, whatever, so it's getting a lot of resistance, including from MaineHealth, so who knows where it's going to go. But
Right.
It's being proposed by Democrats. I guess it's just Democrats, they just want to do something good for lower costs, right?
Sure.
But it really comes out of the hide of Medicare. If it's twice the Medicare payments, it comes out of the hide of insurance companies, right? Is that where the hospital, where you lose money or not get the revenue?
So we know that the non-commercial payers, so the Medicare reimbursement, Medicaid reimbursement, Medicare Advantage, which is a commercial subset of Medicare, that those fees that we receive do not cover the cost of the care that's provided. So in in our care industry, the way it's set up in the United States today, commercial payers tend to pay more, and it covers that gap. Whether it's right or wrong, that's the system that we live in. So, I mean, Andy Muller, our CEO, and we all agree that we need to have a conversation about the cost of healthcare. There is no doubt that that needs to happen. I think it would be better for everybody if we could have a proactive, holistic conversation about how do we lower the cost of care together, as opposed to legislating one piece of it, right? So if you legislate just reimbursement, you're also missing how do we talk about the fact that we, from a providing healthcare perspective, we have a lot of costs that we incur because of regulatory requirements. Maybe some of those could be looked at as to, are they old and they're not serving the purpose anymore that they were once intended to, and can we ease some of the administrative burden that exists within healthcare? So a more comprehensive and proactive conversation. I think this is one way to get the conversation started, but I'm not sure that just going straight after reimbursement, it creates a reactive environment as opposed to a proactive one. That's my opinion.
And to be clear, this legislation in Maine would, if it passed, would affect all of the hospitals in Maine, but it would not directly affect billing at Memorial Hospital.
Correct.
But the effects on Memorial Hospital would be significant because as part of the MaineHealth system, you've integrated a lot of your administrative work, teaching, and it is probably the most significant partner, Maine Medical Center, when you need to transfer a patient that needs more services.
True, and it's not just Memorial. We are part of the MaineHealth network, but the services in the southern part of Maine, so Maine Medical Center and their Biddeford campus, they support many of the facilities in New Hampshire. So we're not the only ones that transfer patients there. There are lots of patients and lots of facilities that transfer to Maine Medical Center under a higher level of care. So it would affect a lot of the state. And so MaineHealth, Dartmouth, and UVM are tri-state. They work together on strategy and how can we all support each other. So we really are part of a three-state discussion on how we can care for Maine, New Hampshire, and Vermont. And this would have a tremendous effect on a lot of people. It would also impact Boston, right? The availability that we know that they're full on a regular basis, but our patients are going to have to go out of state for the care that they would have potentially received at Maine Med if they have to close services. All of the service people within Maine would have to do the same. So where are they going to go? Because nobody has the availability to pick up that volume. It could affect a lot of people.
This could be like a 3-hour conversation.
It could be.
No, this one coming up.
Okay.
Okay, so let's pretend you're at a dinner party and someone says, hey, Tricia, like how do you lower the cost of healthcare? So how do you respond? We can reduce regulation. People always blame the insurance companies, but you're saying the insurance companies is what really footing the bill for hospitals. Mm-hmm. So people want to take them out of it if it's sort of universal care and just have the government just basically eliminate the middleman of insurance companies. So, and how much of it is it education? We spend so much. How much of it is that we have too many users of of healthcare because of whatever reason? Like, what do you tell people in 2 minutes about how to solve the healthcare costs?
I see this could be a 3-hour conversation. I think there's two things. One is we need to work on getting our population healthy, right? So health care is not necessarily wellness. And that's where those community partners come in. That's where food, and we know that 50% of health care, SDOH, so social determinants of health, your food, your housing, whether or not you have transportation, have a significant impact on your health outcomes, like a 50% impact. It's more than what we can do inside a clinic in your visit. So really finding a way for us to focus on food and nutrition and exercise and just getting people moving and helping them become well, behavioral health, like that is a big component that doesn't exist. Those services don't have to happen inside a hospital. I think as Americans, we think about healthcare and we automatically think of our doctor's office, and it doesn't necessarily need to be that way. On the expense side, there's a regulatory burden and there's an administrative burden of how many people we employ, the processes we have to do for pre-authorizations and things like that, that we probably need to take a good hard look at. And technology can help us with that to some extent. And then we also need to look at, if you as a consumer are buying insurance, where does your dollar go? Right? I mean, when I was growing up, my primary care doctor, we didn't use insurance. My parents wrote a check to him, and so every dollar that they paid went to him. So if you're writing if you're paying $1 for healthcare, where does it go? And then let's figure it out from there.
I mean, doesn't it make sense, you know, the universal care or Medicare for all? I mean, to me, it's the difference between what you pay for premiums and what you pay for the actual health care. And I mean, Medicare works, right? I mean, I'm an old guy. I have Medicare. It's like the best thing ever. So why wouldn't that work for everybody and cut the insurance companies out?
I have no idea. All I can tell you is that I was in the Navy. My kids are in the Navy, so when I was in the service, we had TRICARE, which is the kind of a universal payer. It has its limitations. It's extremely expensive, but it worked for us. We loved it. So I think that there's a lot of conversation to be had. That kind of that's leading into or ties into my take every dollar you spend for your premiums, right? And let's see where it goes. And then go from there. Like if we find that for every dollar we spend, we are legitimately sending 97 cents to care for you, that's not a bad investment.
What is it now?
I have no idea.
I mean, insurance has got, I mean, well, and people talk about, well, you know, CEOs make, you know, $50 million and all that stuff. But
I honestly don't know. But I
would you support Medicare for all, that system? I mean, Medicare works, right? I mean, except that the hospitals don't get reimbursed as much as they want, but the actual system of Medicare works.
It doesn't cover our cost if we just look
Except
at
for that.
Right. So that would be a problem,
Yeah.
right? And I think there are other. This is me personally. Like I'm not speaking for
Right.
anybody other than myself. I think there are other countries that have done it that we could learn from. I don't have an opinion either way. I just know that what we have right now doesn't work. There's nobody that's happy with it. If we were to go out and ask anybody, is healthcare working fantastic? The answer is nobody's really happy with it. Our providing care is difficult, receiving care is difficult, and it's the most intimate thing you have, right? Your wellness, your health is the most personal thing you have, which is the most important thing to people. It's an emotional topic. So we definitely need to figure out how to do it better.
Okay, Terry?
Staffing has been an issue at Memorial Hospital, and I want to hear from you where it's at right now.
I'm afraid to say this out loud. Right now, we are doing okay. I know, knock on wood, right? Our utilization of traveling nurses is significantly down. We do have some traveling nurses or contracted personnel, specifically in the technology side of things, and technology would be respiratory therapy, imaging, so radiology technicians, or surgical technologists and scrub techs. But our nursing, right now, we have a tremendous team, and we actually have people who are in per diem positions waiting for a position to open with us that would fit their needs. So we're in a good spot. We have a great team, and we seem to be drawing people. So
Pretty stable workforce, not a
pretty
lot of
stable.
turnover.
Yeah. Some of our provider staffing, so oncology right now is hard, but it's hard across the country. So that's where we're benefiting with MaineMed to be able to figure out how we can tie into their network that can service our community, and we can keep care close to home for our patients. But other than that, we're doing okay.
Are you doing okay? I mean, housing is always an issue. Is housing not as much of an issue anymore?
Housing is still a huge issue. And we actually have times where we can't, like we've had travelers who have canceled, or contracted employees who've said, I can't come because I can't find a house. I can't find a place to live for 13 weeks. Housing is definitely one of our biggest challenges. Housing and daycare, which doesn't make us unique.
Right. I mean, housing is going to be not solved, but we're going to have hundreds of units in Conway coming online in the next
That
year
would
or
be
two.
wonderful.
Yeah. Have you been in back at TJ Maxx and seen what they're doing?
I have not, but maybe I need to.
It's like, it doesn't look like Conway. You know, I mean, it's just like this, you know, it's just 200 units back there.
That's great.
Yeah. So there you go.
Yes, there we go.
So are there some big challenges you're looking at and addressing right now at the hospital?
I think right now one of our biggest challenges truly is our building and our infrastructure, and trying to figure out how to make the best use of space and how to rehab and rehabilitate the space that we have. So that's an ongoing project. We hope it's been going now for about 4 months. We probably have another 3 or 4 months because it's a big planning piece, and it's a lot of money to bring spaces that haven't been touched in a while up to where they need to be for today. And healthcare is ever evolving as we implement new technology. Sometimes that comes with a need to do infrastructure changes.
So how big is telehealth now for what you do? It was very big during COVID, and I think people have backed off a bit, but
I think they've backed off a bit. We do. It's a tremendous, if the patient, that's the way patients want to receive care. So there's a lot of people who want to see their provider. They want to come in and have a visit. We utilize telehealth to some extent, but we definitely have an opportunity to expand it if that's what our patients want.
I mean, telehealth with your primary, or telehealth just, like, what do you mean I mean, I know what telehealth is, but I always think of it as between here and Portland.
It could be. So there may be opportunity to expand the way we do telehealth in primary care. So if you don't want to come in, you could see your provider.
Do you do telehealth for primary care?
We do, but not as much as we could. And then for the Valley, bringing specialty practice and specialty services, especially subspecialty services that we can't bring a provider up here full time, but being able to connect with Portland and some of our other, and I'm talking specifically on the outpatient side, right? So how do we, maybe in oncology, how do we connect you to your oncologist telehealth-wise? We do use it for strokes. If someone comes into our emergency room and they're having a stroke, we do telestroke. We have tele-ICU. So we do use it on the inpatient side. It's really expanding to the outpatient side.
How many people, like your portal's called MyChart, right? So, and I think it's great. You go in, you know, instead of having to call, hey, I need a script, and someone answers. You know? So what percentage of patients who go to the hospital use MyChart?
It's not as high as you think.
I'm
going to guess, because the last numbers I heard were 5 to 7%, but it's
really,
it's probably grown since I pulled those numbers. It's not a lot.
I mean, isn't it obviously super efficient for both sides?
We think so.
You should promote that. I think, Tim, you should buy some ads. Sorry.
The other piece of that is that you can now register online, right? So you can pre-register for your appointment through MyChart. And we're working on technology where you can tell us you're there and you can just walk right by check-in. So you could pre-register and avoid the check-in process. And we have it. We don't use it as well as we could.
you know, is that part of the On My Way feature of this, or is that
Kind of.
separate?
On My Way is more for the urgent care,
Okay.
where you don't have a set appointment.
So make sure I got this right. On My Way, if I'm looking for someone to address the cut I just made in my hand and I want to go to urgent care, I can go to my chart or just the website, and I can essentially book an appointment
Right.
immediately. I'd like the next appointment, 4 o'clock, 5 o'clock, whatever it is.
I'm not sure I haven't done it. I'm not sure it's an appointment-based thing as much as it is saying, hey, I'm on my way and I'll be there in 20 minutes.
So is like getting in the waiting line at a restaurant?
Kind of, yes. And it allows them to manage their rooms, right? They may hold a room open if you're on your way and you just haven't got there yet. So,
And the hospital is not using that because you book appointments in advance.
right.
Okay.
What about AI? You know, Elon Musk says in 5 years you don't have to go to medical school.
Oh, that's scary, isn't it?
A little bit, but I mean, it is amazing, right? I mean, what AI, so as are you actively, is the hospital actively using AI? Like I know with like
We do.
reading radiology and all that kind of stuff.
So one of the places where we use AI the most is a program called a Bridge. And so if you come in to meet with your primary care doctor or one of our outpatient physicians, they may say, do you mind if I use my phone? Right? And they'll set their phone down. The phone is listening. It's our AI, and it's writing the note
Sure.
while they talk with you. So it allows them to have their relationship as
Without-
opposed to having a keyboard in the middle. It's been well received. Our docs and our providers love it, and our patients seem to enjoy it too. So it's a win-win for everybody. That would be a use of AI. We do use AI for some of the back-end administrative stuff, like when claims are denied. AI, we're working on being able to use AI to help us fight denials, things like that.
Interesting.
And MaineHealth recently implemented an entire technology oversight committee, so moving into AI is something that we're deeply dedicated to. But not removing the relationships that people have to
I don't know.
we place a lot of value in education.
I mean,
so I'm
it is
not
an
sure.
interesting concept because primary care, which they're, the docs are great. I'm not
Yes.
saying that, but it's changed. So now if you go in and you get something pretty serious, boom, you go to a specialist pretty quickly. But boy, to have that on your phone and just monitor you and say, look, you got a that issue, it doesn't take care of primary care docs, but it can go a long way in directing you to the right situation.
It takes healthcare to the patient, right? AI in some ways is bringing healthcare out of the facilities and to the patient wherever you are.
But that's good.
That's that's
And it's
wonderful.
more control.
Absolutely. For us, it feels like less control.
Right.
But we didn't really have control anyway. Like we can't tell you, we have no control over whether or not you follow through on the plans that we made in the exam room, or whether or not you pick up your medication, or if you're changing your diet, or if you're exercising. We're influencers in some ways.
Very, very modern language there. You've been in healthcare your entire career. You started out as a CNA and now you're the hospital president. You've been a medical corpsman, which is
Correct.
equivalent of a CNA or different?
More like an LPN.
Okay. I'm wondering over that period, and you've traveled. I'm wondering over that period, like, what's the best change you've seen in healthcare?
I like a bridge. I think the technology that took computers out of the way, because I feel like the EMR was necessary but not great for actual health care. That would be technology where we're at today. I also feel like as hard as the COVID period was, it forced healthcare to change, and it helped us change rapidly, which is not something, we're a very risk-adverse industry, so it helped us change in ways and be open to change. And it also built resiliency and confidence in a healthcare team to say that we can do this, and that matters. That allows us to be a little more fluid with how we do things and to look at, like, go north, right, and opportunities to do things better or to do things different. It gives us the confidence in our staff to be able to say, change isn't always bad. So there's always got to be a silver lining. That's my COVID silver lining.
Okay.
You done?
I'm done.
Okay, I got one more.
Okay.
Here's a legacy question for you.
Okay.
So I was just thinking about this before. You know, Scott McKinnon, when he was here, whatever it was, 10 or 15 years ago as president, he was here during when MaineHealth was, the whole merger was taking place. And things kind of went sideways a little bit. There was a lot going on. Epic came in and all that. And then Art Matheson, when he was here for his 3 or 4 or 5 years, he really got at least from my perspective, he really got the trains to go on time. Like he just, everything started working well. And then we had a couple of interims, and who knows about them. So there's been some serious and major changes. What do you think of your legacy? Like, what's the stamp you want to put on the hospital as we go forward? And we went through the merger, we went through getting things shipshape with Art. What's next?
This has always been my legacy, whether it was at Memorial or not. My hope is that my influence can be that the hospital becomes a true community partner, and that we can I truly believe it takes a village, and that we can work together to do our part and do it really well and work with our partners in the area to do the same. I think the community benefits the most when we all work together. And so I believe that healthcare, like we talked about, if you say to most Americans, you talk about healthcare, they picture their clinic or their hospital in their head. And I'm hoping that I can help have an impact on our community that we switch to wellness.
Very good. Tricia, it's been a pleasure.
Thank you so much. I love coming.
Thanks. Terry, always nice to see you.
And
I'll
you as
see
well.
you upstairs in a few minutes. Okay. Thanks, Tricia.
Thank you so
Okay.
much. It was great.
Okay.